So let me go. I give some hypothesis. In fact, it was helped by one of my friends, Raghu Yadav, who had done a lot of research on this COVID. And I was having a lot of discussion with him for the past 2 months regarding this pathogenesis. So I like to give you the pathogenesis in three forms. See, after all these COVID children or adults, there is no specific pathogenesis for children as such. So any pathogenesis to get developed, you should be either from autopsy or from the clinical spectrum. Okay. So this pathogenesis with the hypothesis which I am going to tell you now is done mostly from autopsy done in Maharashtra. Most of the COVID patients were undergone autopsy and a lot of research was done. And some of the pathogenesis was postulated based on the autopsy. And the pathogenesis is also correlating with the clinical spectrum. So to understand easily, there are three things are happening in COVID patients. Number one is hypoxia. Number two is some inflammation is taking place. Number three, there is a microthrombi formation. Only our target of treatment is only these three. So how this hypoxia is occurring in COVID patients, we'll see one by one. So first I want to say about the Lewis Thomas theory. This theory is very simple. Usually the organism is always a bystander. They don't cause anything harmful to us. But the response which our body is going to produce to these organisms in the form of inflammation, I would say arsenals, they are the persons who is going to cause a lot of problems. So COVID also is similarly like that the response which our body is producing to this organism is having a lot of problems. Okay. So let me go first hypoxia. Okay. You can see the diagram here. So you do please take it as an alveoli. So just or two alveoli I have shown you. And you can see two small cells also there in the alveoli. Okay. The cell which is present in the bronchoalveolar junction, that is in the top one, the dark blue, that is called Clara cells. And the cells which is present in the down is called pneumocyte type 2 cell. Okay. What is the function of this Clara cell? The Clara cell is a wonderful anti-inflammatory cell and it secretes surfactant proteins also. And you can see in the slide, beneath the alveoli, you can see the pulmonary vasculature also, through which the pulmonary artery receives oxygen from the alveoli and goes to the heart. So let me see what is happening when the child or the adult getting infected with COVID. Now, you now see the second slide now. See, one of the alveoli is becoming smaller, the other alveoli looks normal. Here, what I mentioned, the Clara cell, which is present in the bronchoalveolar junction, is becoming somewhat ineffective or attacked by the COVID virus. So what happens? Anti-inflammation will not be there. Since Clara cell is producing surfactant, there is a chance of alveoli going for collapse will be there. The third most important point we should remember is called hypoxic local vasoconstriction. You can see in the picture, beneath the normal alveoli, you can see the normal pulmonary vasculature. And beneath the collapsed alveoli, you can see a narrow pulmonary vasculature. So what is happening? Why the pulmonary vasculature is becoming narrowed? See, when the Clara cell is getting infected, there is no anti-inflammation and there is a collapse of the alveoli is taking place. When the alveoli is getting collapsed, you can see the PO2 within the alveoli will be very low. And the space between the alveoli and the pulmonary vasculature, that is called interstitium, there also the PO2 will be very low. When both this PO2 is very low because of the collapsed alveoli, the mitochondria in the pulmonary vasculature senses this and produces what is called potassium channel blockage and open up the calcium channels, which causes vasoconstriction. That means the vasculature which is going near to the collapsed alveoli undergoes vasoconstriction. It is a very good advantage because when the vessel is unconstricted, the blood supply to this useless alveoli is being stopped and the blood supply may be diverted to the other alveoli. That's what we see clinically, that when the child or adult getting COVID, after 2-3 days or 5 days, 6 days, if you take a CT chest is showing a ground glass appearance, say 5% or 10% or 15%. But child or adult is not having any symptoms. There was no distress or there was no hypoxia and there was no reduction in the oxygen saturation. That is because the pulmonary vasoconstriction, the hypoxic vasoconstriction which occurs in the vessel is not supplying blood supply to the damaged alveoli, but is taking care of the other alveoli where the pneumocyte is still active. So this hypoxic vasoconstriction is an advantage for the patient. At the same time, the patient may not show you any signs or symptoms. Maybe the patient may say after the exertion there is a distress, but still the saturation may not come down, hypoxia may not set in. This is what I want to term it as what is called as C type of COVID. That is the Clara cell getting affected and producing COVID. I say C type of COVID, where I can see the ground glass appearance in this one. So what happens? So many cases are asymptomatic, but you can see a ground glass appearance in the CT. Distress and tachypnea may be there, but the saturation will not come down. Your high flow nasal oxygen will help these children, and fever and inflammation will be treated accordingly with steroids and immunomodulators. So barely they need ventilation. Okay. Now let us go to the next scenario. That is P type of COVID. Now you see the picture again. I have showed you two alveoli. Again, the Clara cells in the top and the pneumocyte type 2 in the lower. So what is the function of type 2 pneumocyte? The type 2 pneumocyte again produces surfactant, number one. Number two, it is very important to maintain the integrity of the alveolar membrane. When the type 2 pneumocyte is getting affected after some days, so what will happen? We'll see now. You can see now the type 2 pneumocyte is getting affected. So the surfactant goes down. That means the alveoli has to go for complete collapse. But fortunately or unfortunately, it is not happening because the integrity of the alveolar membrane is being lost. So a lot of water and inflammatory cells comes into the alveoli. That's what the blue dot shows, that comes into the alveoli. When the inflammatory cells and water enters the alveoli, now the alveoli is in a state of partial collapse. Because of the surfactant deficiency, there is a collapse. At the same time, there is water and inflammatory cells inside. That means this partial collapse, the reduced PO2, may not be sufficient to produce, and the leukotrienes or the inflammatory cells which is present inside the alveoli will cause pulmonary vasodilatation rather than pulmonary vasoconstriction. The Clara type we see hypoxic vasoconstriction. Here the vasodilatation is there. Thereby unnecessarily blood is being supplied to this damaged alveoli, so that other alveoli is not getting further blood supply. What happens? Other alveoli is getting there. So as an increase in saturation, increase in ground glass appearance in the system in CT, the child is going for the next symptom. So because here the pulmonary vasodilatation is a problem. Previously I saw vasoconstriction is a blessing in disguise. Here the vasodilatation is supplying the damaged alveoli, not supplying the good alveoli. What happens? There is a problem now. So what are the clinical scenarios going to have? You can see the leukotrienes. The leukotrienes is the one which is going to cause the vasodilatation. So there is an intrapulmonary shunt occurs here. So what happens because of this? Initially there was no distress, there was no hypoxia, the saturation was not going down. Now the child develops hypoxia because the type 2 pneumocyte also is getting involved. Because of hypoxia, the child may go for decrease in saturation, and now we started seeing a decrease in saturation in this. The carbon dioxide may be near normal, but saturation is very low in the course and it is going to progress. So hypoxia now will not respond to oxygen. Now the hypoxia is not responding. That means we can see the clinical spectrum. In the first 5-6 days, the CT chest is showing a 15% of ground glass appearance, not needing any treatment, not showing any decrease in saturation. And the next 4 or 5 days, when the CT cell become 40% and 50%, what happened? Now the pneumocyte 2 also is getting affected. Now there is a need for oxygen. Now there is a need for high intervention for this child in saving this child. So that means this hypoxia per se is causing a problem. When the Clara cell is getting involved, you get one picture where the saturation is not coming down. But when the pneumocyte 2 is getting involved, now the saturation is coming down. That's why a clinical symptom like respiratory distress or tachypnea is not very significant in many patients. Very significant is you have to measure the saturation every day. So saturation and respiratory rate is the two important findings that everybody should concentrate, even the person is asymptomatic. The asymptomatic person on the 5th day, 6th day, you may be happy that saturation is fine, but 1 or 2 days or 3 days it may go down. So please keep watching the saturation. So that is the one postulate, the hypoxia causing damage to the lung. But in children, I have seen around 75 children I have taken CT chest. Out of the 75 children, 20 to 25 children had ground glass appearance of 15%, 20%. In fact, one leukemia had almost 70% ground glass appearance also. But this 15, 20% need not had any oxygen treatment or anything, but the 70% had some need of treatment. So this is one hypothesis. Now the next two I told you, the microthrombi formation and the inflammatory storms. See, any virus or bacteria, when they enter our body, it is going to produce two important actions. One, it is going to activate the immunological cells. Number two, it is going to activate the complement system. When the immunological cell is getting activated, it is going to cause endothelial damage. At the same time, when the complement system is activated, what is going to happen? There is one thing called MAC, that is membrane attached complex. This MAC, membrane attached complex, using the complements of C5b, C6, C7, C8, C9, they may cause endothelial damage. So both this complement system and the immunological system is going to damage the endothelium. But that is what we call as endotheliopathy. This endotheliopathy, we have seen in dengue that there are two pathways. One is called capillary leak, other one is called the coagulopathy. Similarly, here there are two pathways. One is called the inflammatory pathway, where you are going to see a lot of cytokines are going to be released, and these cytokines will go and attack most of the organs, and they may put in what is called SIR, systemic inflammatory response syndrome, where you can say CNSD, CNS system can be affected, ARDS can come, hemolytic uremic syndrome can come, hepatic failure can come. That means multiple organs can get involved because of the inflammatory pathway. The other pathway, what I said, is called the microthrombotic pathway. Here, what happens whenever the microthrombotic pathway is activated? There is one thing called ultra large von Willebrand factor. This von Willebrand factor are usually being released by endothelium as ultra large von Willebrand factor. But this ultra large von Willebrand factor will be cleavaged into smaller groups, and they have become ineffective by means of what is called ADAMTS13. That is a dystagrin metalloprotease thrombostompin. So this protein combines with von Willebrand factor and makes them ineffective. And unfortunately, in COVID situation, where because of the inefficiency of this ADAMTS13, or it is not very effective, what happens? All this ultra large von Willebrand factor gets into the endothelial cells and attracts the platelets and causes aggregations. So what happens? Because of this aggregated platelets, because of the large number of ultra large von Willebrand factor, there is a thrombocytopenia and there is a microangiopathic hemolytic anemia. Both together will lead to what is called thrombotic thrombocytopenic purpura. That is called TTP. In this situation, a lot of microthrombi is going to be formed, and this microthrombi can involve any organ and can cause damage. In fact, some of the postulates says that the myalgia in the adult, which is extending for 8 days, 9 days, and 10 days, may be due to the microthrombi going to the small vessels to the muscles, that is causing the myalgia. In fact, if you would have tested a lactate in this, it will be really high. So this is the three pathway. The hypoxia is causing the lung damage. The inflammatory pathway is causing the multiple inflammatory syndromes. And you get the microthrombotic pathway where you can see microthrombi producing this problem. So you can see this pyramid. This is what the most important pyramid we like to see here. Okay. So this SARS-CoV-2 virus may be associated with PIMS. Okay, it can involve multiple organs and produce an inflammatory syndrome. Or it may be associated with Kawasaki-like disease. Or it may be with FIS, means febrile illness syndrome. So this is the FIS-TS. This green is very important because now Tamil Nadu has witnessed around 20 to 25,000 children being admitted in 22 medical colleges, out of which ICH, in person, I have treated 1,000 COVID children. Out of these 1,000 COVID children, 80% are asymptomatic and 15% had some symptoms and 5% maybe a little bit of sickness may be there because of the associated comorbid conditions. So what we have seen here is the FIS-TS. That is, there is a fever. So what is the take-home message is, rather you should expect any child who is not having fever after 2 to 3 days is not going to be in trouble. But any child who is going to have a persistent fever even after the 5th day or 6th day or 7th day, that is what you say inflammatory cascade syndrome or the cytokine storm has taken place. And you should see that whether any target organ is getting involved. last year, when I was treating a dengue cases, around 40 to 50 cases had a raised level of LDH, CPK, ferritin. In fact, ferritin has gone up to 30,000 also with the liver involvement, somebody with kidney involvement also. In fact, last week, I was treating a secondary dengue with the renal damage, creatinine going up to 3.5. And after a meticulous treatment, the child has come back to normal. So whenever you have a fever with inflammation, you should see that whether any target organ is getting involved. What we practice in ICT in these situations where the target organs are not involved, these are the inflammatory children are responding to the steroids, and mild dose of steroid, they become already 1 to 3 days. So out of these three, whether it's a PINS with TS or KD with TS or FIS with TS, what ICH is witnessing a more number of cases of FIS with TS. So the implications, symptoms of distress less reliable than objective signs. So what is most important? Two things we should observe in this child. Respiratory rate you should monitor. Saturation monitoring is very much mandatory as per WHO norms also. So suppose a child comes to you with more than 20 respiratory rate, but the saturation is normal, the distress is not that much. There is an involvement of some alveoli. It may be a C type of COVID where the Clara cell is affected. Suppose the oxygen saturation goes below 90, that means the child is going for P type of COVID. But apart from Clara, pneumocyte type 2 also may be get affected. So saturation monitoring is becoming very mandatory. As far as ICH is concerned, we have treated so far around 1,000 cases, out of which around 572 cases are with symptoms and around 300 to 400 cases are without symptom, and we have permitted them for home quarantine. So you can see many cases, 455 cases came with upper respiratory tract infection. And we received around 25 to 30 cases from Adyar Cancer Institute with all acute lymphoblastic leukemia and myeloid leukemia becoming COVID positive and being referred to ICH. And we treat these patients for 1 week to 10 days. We take CT chest, we take inflammatory markers, we do everything. We do antibody also. We do a repeat swab test, even though government doesn't recommend repeat swab tests. We do a repeat swab test for these children. And what we have found that this leukemic children is taking a long time to become negative compared to the other children. Invariably, the URI children or the LRI children or children with pneumonia, they become COVID negative by 9th day or 10th day. But what we have seen in leukemia children, they become negative by 14th or 15th day. And the antibody starts arising not on the 3rd week. It takes sometimes 3rd to 4 weeks to rise. So important case on the anemia, we had 5 cases, SAM1. Neurologically, we had 1 GBS with the COVID positivity. 1 hydrocephalus children is with a comorbid condition. CVS, one interesting case, CVS also we had in ICH. In fact, it has come in today's news also that long QT syndrome. See, this child came admitted with respiratory distress and fever for 5 days. So the child since become COVID positive, I have taken over to the COVID ward. Initially, child had a mild pleural effusion and there was a mild pericardial effusion also. So being a girl of 12 years with this nature, we thought of maybe we are dealing with autoimmune also. So I was investigating the child to rule out systemic lupus erythematosus also. Unfortunately, all these findings came something negative. Then suddenly what happened after 3 days of treatment, and I started the child with some antibiotic and we have given azithromycin also. After 2 to 3 days, one afternoon, suddenly child bradycardia. And when I saw the monitor, it was a torsade point is, and we are worried. We stopped the azithromycin, treated the child with the magnesium, treated the child with calcium. Child's ionized calcium was almost 0.4. Then finally, we made it a diagnosis of long QT syndrome. A long QT syndrome presenting with torsade point is, with the excellent intervention from the PGs, we are able to save the child within 45 minutes to 1 hour. It has been a wide coverage by the government today in most of the news also. So this is one of the special case, a COVID 12-year-old girl, female child, presenting like an SLE, had pleurisy, had pericarditis, had long QT, had a mild pericardial effusion. Now after 14-15 days of treatment, now the child is absolutely normal and the ECG has come back to normal, the long QT has come back to normal. So what I'm trying to say, the point is, we should not prescribe azithromycin left and right, especially to the whole children. Better to take an ECG because this QT syndrome, we don't know whether it is existing prior to COVID or it has come during COVID or is it because of calcium and magnesium deficiency. We are working out with this child. That is an interesting case we had in ICH. And we had SLE presenting with COVID for five cases where there 50 to 75 newborns came with some newborns with sepsis, and most of the newborns with the anatomical malformation, they become positive. As far as the vertical transmission is very low compared, it's very less than 2% from the mother to the child, and some child presented with malformations, the diarrhea, and 1 or 2 children presented with diabetes with very high level of sugar going up to 400 and 500, which was effectively controlled with insulin. And most importantly, I should also recognize the pediatric surgery department in ICH, which is doing a wonderful work. So many surgeries they have taken up with the emergency surgeries without knowing the COVID status, just taking care of the child status. They did surgery, then they become positive, and most of the post-operative care was given in COVID ward. We had some very interesting case, 2 to 3 appendicitis, then malrotation we had. Last week we had a biliary polydacal cyst rupturing and producing a biliary peritonitis, and child going for myocarditis with the raised inflammatory markers, now getting settled in COVID. So the journey is there. So there is a lot of comorbid conditions and other conditions comes with this COVID. In fact, ICH is treating all. In fact, I should also appreciate one of my director who was given a lot of freedom to work on these cases, and also my another chief, Professor Luke Ravi, who is also working with me for the past 5 months in COVID ward. So this is about our journey in ICH. So let me stop with this about the hypothesis. Because this hypothesis, it is long time, maybe it takes another 1 year to come out with a very correct hypothesis. At present, we should concentrate on how to manage an hypoxia, how to manage a microthrombi if it is going to be formed, and how to control the inflammatory markers if the child is going to have inflammatory markers. Thank you very much for giving this opportunity to the IAP CCB Chennai. Thank you.
Thank you, sir. Thank you for excellent presentation and throwing a light on the pathogenesis. I have a question for you, sir, from Dr. Sarat Chandra. Is there any role of doxycycline or ivermectin for COVID treatment in children?
No, sir. No, sir. No drugs. We have the government guidelines also. We have not used